Well, hello, friends, and welcome once again to another episode of the 360 Experience podcast. I'm your host, Tim Braheem, and I want to tell you a little bit about my special guest today. This is a man who I've known for over 15 years. He's been my primary doctor, my general practitioner doctor, Stephen Tenenbaum, and he's quite a man on so many levels. He combines the unique abilities of being a Western medical doctor of significance. He's a graduate of Penn State University, which is where he has his doctorate degree, with a real wisdom as it relates to nutrition, vitamins, other forms of supplements, as well as the psychological aspect of health. And I have so many of my clients who come to me as their coach and ask about what they should be doing to take good care of their health. And let's face it, if we don't have our health, we don't have anything. It doesn't matter how much money we make. It doesn't matter what places we've traveled to. I mean, health is the most important thing. And Dr. Tenenbaum has taken a very unique approach to health over the years that I've known him that is incredibly proactive and very holistic. In this episode, we're going to talk about a wide range of things. He's a very articulate man. I think you're going to enjoy it very much. We're going to talk about everything from the type of blood work that you need to be getting done and the frequency of it, to the types of supplements that would be appropriate for one to take to stay healthy, to the psychological components of health, as I mentioned before, for men, testosterone replacement therapy, the prostate and how frequently you should get your prostate checked, and just longevity in general, how to live longer and a healthier life, and the difference between different types of scans such as CTs and MRIs, and when one would be more appropriate than the other. I think that you're going to very much enjoy this episode. I hope you do. And before we get started, and my conversation with Dr. T, as I refer to him, I want to remind you that this show is one that really, desires to have your subscribership. So if you haven't already subscribed, please do. It's how I get great guests like Dr. Tenenbaum. And if you're watching us on YouTube, give us a comment, forward it to friends. This episode in particular is one that I think will be very ubiquitous. Anybody that you know might benefit from this conversation that we're going to have. And if you're listening to it on one of your favorite podcast channels and you want to give us a thumbs up or a like, that would be great. And without further ado, it is my great pleasure to bring you my conversation with Dr. Stephen Tenenbaum and the 360 Experience. Hey, doctor, how are you?
I'm doing great.
It's good to see you, and thank you for being here with me. I conceived this idea probably about a year ago that I wanted to have you on my show, but I didn't approach you with it for a while just because I know how busy you are, and I just am grateful that you've taken the time to be here with me.
Thanks for having me.
So let's just start with a little bit of a background, and I'm going to embellish a little after you share, but what is your background in medicine? I mean, you're technically a general practitioner, but tell us about your schooling and, give us a quick overview on, where you've come from.
Sure. So I can give you a kind of update of how I got here. So I'm a general practitioner now, but I'm actually from Thousand Oaks, California. So from Southern California, born in Detroit, but I came here when I was a little kid. And then I went to local high school, Thousand Oaks High School. Then I went to UC Santa Barbara. I want to be a doctor since I was a little kid. So it was when I was in high school and in college, it was very pointed why I was there. I kind of was mission driven. But I went to UCSB, and then I had 2 years off between college and medical school, not by choice. It took time to get into medical school. And that was actually a really amazing time. I get to do some fun things, live in Argentina, teach ballroom dance. I was a bilingual kindergarten teacher, some really fun things. And then I went to Penn State for medical school, and I thought I was going to be like all guys who like sports, you think you're going to be an orthopedic surgeon. So then I hung out with the orthopedic surgeons, and it was kind of like, I don't know, like fraternity gone wrong. So up in the middle of the night at 2 p.m., taking care of old ladies who broke their hips, and the surgeons were really like downtrodden and beat up upon, and of course naturally that affected their sense of humor. So anyway, I ended up not deciding to do that. I thought I was going to be an ophthalmologist, all sorts of things. But for a whole host of reasons, I ended up becoming a general practitioner. It's been awesome. It's surprised how wonderful it's been. And I've had some different jobs. I worked in an ER for a little bit of time in Ohio. I worked in a integrated medical practice in Ohio. Then we moved back to California, where my wife and I are from. And I've been working. I worked for a few other places for a couple of years, and I started my practice about 20 years ago. And I've been doing my thing since that time.
Right on. That's a great little background. You're also the first person that I ever heard utter the very popular phrase pickleball. You started playing
Uh,
pickleball a long time ago now. I know that you also love to
pretty
surf.
cool. It was
Yeah.
pretty cool. Yeah.
Yes, you were definitely a trendsetter. You were one of the people who probably
Or
got the craze going, I'm sure.
friend center or a dork. It could be seen either way. Yeah, I
Well,
don't
I
think
mean,
it was cool.
it's the fastest growing sport in America, so I think that there's a lot of dorks then if it falls into that
Oh yeah.
category.
Well, back then, like I'm saying, it was a little bit more dorky. I don't think it was until the pandemic and you had a lot of other like pro athletes playing that somehow it became like fun. It's super fun. I still played. Actually played this morning, so I love it.
Well, one of the things I'll add that you also do that I think is extremely noteworthy that I have, lots of clients who, I coach, and a part of that coaching curriculum is health and wellness. And it's kind of astonishing to me as to how reactive most people are to their health. Then where I'm, as you know, very much not that way. I could probably afford to be a little bit more reactive, but I mean, it's what I love about having you as my doctor is that you take a very proactive approach. And I have a lot of people that have been asking me lately if I know of any concierge doctors because it's become something that is very popular. And that's something that you transitioned to maybe 4 or 5 years ago, which I'd love for you to just comment on that real quick, which is what is a concierge doctor? I think it'd be helpful for people to understand the difference between that and a kind of a traditional doctor.
Sure. So usually a concierge doctor is a primary care doctor. So it could be an internal medicine doctor, family doctor, general practice doctor like myself, who is either has a lot of patients to start with, and then they are usually getting a little bit exhausted from just having a huge patient load, which could be like 3,000 patients. And then they decide to charge an annual fee. This is how it's typically done. You charge an annual fee to whittle down the amount of patients so then you can make a decent living taking care of fewer patients and be way more attentive to them. So the concierge part is to, just like if you want to text me or email me, you can text me or email me. If you need to be seen, I'm happy to see you the same day. So it's that aspect of getting like care when you need it is, I think, awesome for the patient. It's also awesome for the doctor. Instead of having someone call, and it's still weird if someone calls the doctor's office and say like we have an appointment in 3 months. Like,
Mm-hmm. Mm-hmm.
that's fine if it's a routine appointment, but it's not fine if you actually have a medical problem. So concierge medicine has basically morphed because of that. So there's so many more patients who need more attention than there are doctors and nurse practitioners to take care of them. That's kind of what's happened. And, it was hard for me to make that decision actually to go concierge because I've always felt like, hey, like that seems like mean to do, like charge patients, a significant amount of money to take care of them. It doesn't seem particularly caring to do that. But for self-preservation and for the patients who can afford it, I think it's been very good. What's your take on it?
Oh my
How do you
goodness. I
feel?
mean, I have a lot to weigh in
All right.
here. I mean, the the difference in the level of service and care that you provide to me as your patient is astronomical. I would never want to go back. I mean, for anybody who has the fortune of being able to afford to pay the annual fee for a concierge service is really going to benefit tremendously. I mean, I remember the days when I'd come in your office and I'd have an 11 a.m. appointment. I used to tell Michelle, like, can we have the first appointment of the day? Because I knew that then I would probably get in when I was supposed to. But there were those
Right.
days where at an 11 o'clock or 2 o'clock, and I'm sitting there for an hour past my appointment date because see, the thing is in addition to the fact that you had a lot of patients, there's also something that is very noteworthy about you that I know from experience is that you do care. So you're not one to shoo somebody out of your office and make them feel like you're rushing them. I mean, you're incredibly attentive and present when dealing with your patients. So I could see where it really it really served you better too, because you could be more you rather than
Yeah.
being somebody that's just kind of like running a doctor factory and trying to churn people through. So, yeah, for those that are taking note of this, I mean, it's something that I think is well worth taking a look at if you're the kind of a person that wants to have a little bit more attention and not feel like you're just a number. And that's absolutely how I feel. So I'm really thrilled that you actually made that transition. The other thing that I mean, the next thing I'd like to talk to you about, so we dive a little bit deeper here, is I've always revered, in addition to your compassion as a doctor, I've revered you as being a well versed in a variety of medical modalities. So, I remember when my knee was bothering me and you knew who the knees over toes guy was on Instagram, and I was like, wow, I mean, because most medical doctors don't take the time to, or don't have the time to look into other modalities, or the variety of different times that instead of prescribing, a prescription medication to me for something such as my cholesterol levels, you also offered an alternative of something I could get at Whole Foods that would be a natural supplement like red yeast rice. Um, Tell us a little bit about your philosophy on medicine as it relates to the difference between the pure Western medical approach versus alternative forms such as homeopathy or nutrition, things like that.
Sure. Well, it's interesting because like I always want to be a doctor, but there's a natural part of me that's a little bit rebellious, which doesn't believe stuff. So I'm a skeptic with most things. So I'm a skeptic of like regular allopathic medicine. That's what MD, I'm an MD. So the MD medicine is called allopathic medicine. That's a whole aside of why it's called allopathic, because homeopathic came before allopathic. So it's considered on the side instead of being a homeopathy, it could be an allopath. Anyway, so this allopathic form of medicine is like in many ways awesome. That's what you think about like a real doctor, right? Like when you go to the emergency room, you don't want to see like a homeopathist. You
Yeah.
need someone who can like actually take care of your medical needs, or a surgeon or something like that. So that aspect of being a doctor, I love, because it's like it still feels like being like a real doctor and being able to really help somebody. But pretty quickly you learn that, hey, if that's the only way you're practicing, you're doing a disservice to your patients. And then there's much more gentle, nice ways of doing things. And being a skeptic, you also wonder like the research, there's a standard of care for everything. And you wonder how that standard of care was made. So this is just the skeptical part of me. As a general rule, someone comes up with a new drug and then they get the thought leaders in that area. So let's say you were a professor at Harvard, you would be the one who would do the research on my new cholesterol medicine. And then if I'm the pharmaceutical company, then I pay you to give lectures. And then it just so happens to be that you're on like a board that makes recommendations to like the Society of like Clinical Endocrinologists on like hyperlipidemia, or cardiologists. So then you're the one making you're the thought leader who's now being paid by us to do research. And then you make recommendations that say, hey, you should use this medicine. So it's healthy to have a little skepticism with like modern medicine, because there's so much money riding on some of these things that I don't think always these are like the healthiest and best ways, even though some of these, the research is on some, there's research on anything. So you can decide what to do, what you want. With regards to like how I got into it, I don't know. We all have like a different bent. Like, so if you're a skeptic, I remember my first, I went to Penn State, and then my medical school was, you could choose two types of pathways. You and I have never talked about this, but there's two pathways in medical school at my medical school at the time at Penn State. You could either be problem-based learning, where you basically sit with 5 other medical students and like a doctor, and you do case-based learning, which is like super awesome. That's the way I like to learn anyway. And you don't take individual classes like pharmacology, or histology or pathology. It's all based off cases. Like you're seeing cases and then you're like working up these cases. The second way you could do is you could be in a lecture all day. So I did the problem-based learning curriculum because it seemed like that's what it's like to be a doctor. And I like learning by doing. I'm very much like, I don't want to just be told what to do. I need to do it in order to learn how to do it. So I remember there was one case we had where it was just like a simple case where the person like sprained the ankle, and the person who was our moderator, like the doctor in the room, he's a surgeon. So he's like, okay, what are you going to recommend? And it's anti-inflammatory. I'm like, well, why are you going to use an anti-inflammatory? He's like, because you got to get rid of the inflammation. I'm like, well, why is there inflammation there in the first place? Is it there for a
Mhm.
reason? It's like, he was so frustrated by me asking these questions, you know, just, hey, because that's how we do it. Now, like anything, there's a reason why to do that, but there can be post facto. I can tell you why, but it's interesting that the average doctor gets frustrated if you start asking too many questions, like why do we do that? Why do we do that? Not everything's evidence based, and not everything makes a whole lot of sense. So in medical school, I used to like just study my traditional medical stuff, and then after 9 p.m., I only studied like natural things. So if I had a case on something, I would study, hey, what would be the natural treatment for that, and that helped kept me kind of into. I've always been into integrative medicine, right, combining the natural with the pharmaceutical stuff, and that kept me, I think, balanced. And then when I got out of, I'll tell you a quick story. When I got out of my training, I was in this emergency room and there was a nurse there. And the nurse said something that I thought, like, like you roll your eyes. Like, she said, "Oh, Dr. Tenenbaum, you got to meet my doctor. Dr. Chappell, he saved my life." And you're like, "Oh yeah, sure. He saved your life." Okay. Because we're in the ER. So sometimes you save someone's life, but this was not a doctor who like saved her life. But she had rheumatoid arthritis, and he had basically put her in remission in a natural way.
Mm.
And she would tell me like almost every day, "You got to meet him. He's like an amazing guy. He's an amazing guy." So I actually met him, and I actually started to work for him. And he was an amazing doctor. Even now, I'm 52 years old. He was at the time probably 60 years old, and I was 28 or something like that, 28, 29. I don't even think I'm as good a doctor today as he was back then.
Mhm.
He's an amazing doctor. I have a slightly different skill set than him, but he was just an amazing doctor. So just seeing how you can treat patients and think out of the box and not be stuck in a certain modality, to me, is like very freeing, instead of just like, hey, you have this disease, therefore I can only give you this treatment. Actually think a little bit deeper and investigate things. To me, it's awesome. It just gives me a lot of options.
So where do you suggest that people investigate? And before you answer that question, because you said there's information out there everywhere, there's also too much information that can cause someone to overthink things and self-prescribe and start worrying and all of that. But like, what are like the best sources, in your opinion, for someone like me to go and do a little bit of homework and research on my own behalf?
Oh, okay. So I think, let's say we're talking about something simple. Let's say you have a meniscus tear, right? So we talked about like knees over toes, guys. So let's say you have a meniscal tear in your knee, and it hurts on the inside of your knee, and it hurts when you twist, and you hurt it, and it's not getting better because now it's been 4 months. So and you just do a Google search, treatment or alternative treatment for that. You'll get all sorts of like people making certain recommendations. But if you want to like learn the best, and like, how do I learn stuff? I still look at research. There's plenty of research on natural treatments, but I kind of know what to look for. So for example, I'll go into PubMed, PUBMED, that's PubMed. And this is the National Library of Congress that lists all the studies that are done. And this is what the doctors look, right? Because I can't, if I make a recommendation for you, either the recommendation could be like, "Hey, Tim, I've done this like 1,000 times. There's no research on it, but I've done this 1,000 times and it works." That's valuable. But more likely, anything that I've done 1,000 times, there's been research on, right? Because if I've done it so much and I have that experience, someone else has the same experience. So you could go on PubMed and you can kind of type in anything. You can write, alternative treatments for meniscal tears, or non-surgical treatments for meniscal tears. Or sometimes it requires me thinking first of like, hey, what would be beneficial? Like, will turmeric, for example, which is naturally anti-inflammatory, will that help a meniscus tear? I don't know if it's going to help a meniscus tear heal. It'll probably help with pain. So I could type in quickly to that search to see what studies on turmeric. Turmeric reduces pain associated with a medial meniscus tear, and then just go from there. If you want to look at stretching or different types of stretching, you just type it in there, and it'll tell you what research is actually done. So almost always when a doctor says like, "Oh, hey, there's no research about that," let's say you came to me with something and you had an alternative idea on a treatment for something like a meniscal tear, and if I'm very dogmatic and you tell me, "Oh, I heard X can help," and I'm like, "Oh no, there's no research on it." Usually what that means is I've never done any research on it, right?
Mm-hmm.
because like how can I know like the totality of research? You
Mhm.
know, you can look up this stuff too. Now, I say to look at it on that PubMed, but you can sometimes when you type in something, especially if you type it in a little bit more medical, the PubMed studies show up, and we look at those studies. Because if you go on like you can of course go on like mayoclinic.com or WebMD, and they give you very general, it's just very general information. The stuff that you want to know and I want to know is like, hey, what has shown to help and what's been researched on, but still that's alternative or what's reasonable in our mind to take, because we'll take a medicine too. If I'm convinced the medicine is safe or a good medicine, I'll take the medicine.
Yeah. So I want to give a case example of this. So a year and 6 months ago, I was on my honeymoon in Europe, and um, I don't know what really happened. I just know that my right knee was really hurting me to the point where like going up and down stairs, and you do a lot of walking in Europe, was really difficult to the point where, and I've had both knees, I've torn meniscus, right? So I know what that feeling is. I know where the location is. I know exactly the feeling. I couldn't straighten my leg all the way. And I told my wife, I'm like, oh my God, I'm going to have meniscus surgery again. I just know it. I mean, this is exactly what it felt like, 15 years ago. Um, I came back. I had heard about the knees over toes guy and started checking him out on Instagram. And then I came back and I had an appointment with you. And that was when I mentioned the knee over toes guy, and you immediately knew who he was, and kind of rubber stamped that as like you should give consideration to that as a form of rehabilitation. And then you also prescribed me with a supplement called, I think it's hydraulic acid. Is that what it's called?
Hyaluronic acid.
Hyaluronic acid. Thank you.
Yeah.
The combination of the two, it's unbelievable. Like I do the stairs, I do these stairs that are brutal when I'm down in Costa Rica, 4,400 steps. I have no pain whatsoever. I completely rehabilitated my knee on my own with the combination of the exercises from these over toes and taking that supplement, which is an example of where had I gone to a different doctor, I perhaps would have gone under the knife.
Yeah,
I
you may
was
have had
convinced.
surgery.
Yeah, I was convinced I needed to go under the knife, but you actually provided me with an option that prevented me from that. Um,
Tim, I was going to tell you, I have this patient who I haven't seen him in a long time, but he's a younger guy. He had a meniscal tear, and then it's the same thing. You go to it's the same pattern. So if you go to a surgeon, the surgeon will not infrequently recommend surgery, right? Because that's what they were trained to do. Or so this gentleman had a tear and he had a lot of pain, and now it wasn't just like a month, right? But it had been a couple months that he was having pain. So he went to see the surgeon. The surgeon recommended surgery, and I'm like, hey, well, why don't you have you heard of prolotherapy? Prolotherapy is where you inject something into the knee. Sometimes it's just hypertonic dextrose, which is just sugar, right? Which sounds like a placebo, but there's very good studies on this helping rebuild cartilage, helping rebuild, even helping heal meniscus tears. So I'm like, hey, what do you have to lose if I give you one of these shots and you get better and you don't have to have surgery? So it's funny because he read about it, he's still a little skeptical, and like literally for years after I gave him an injection and he healed, right? It's not just the doctor. Like if I put in the right ingredients and help the healing cycle, but his ability to heal was great. So it was like a great partnership. I knew what to do to trigger his healing. He healed, and he was just always he'd always come in like very happy that like I pushed him a little bit, right, to like,
mhm.
hey, maybe you want to consider something other than surgery. So that's not infrequent. Having said that, I'm happy they're surgeons, because there's some patients where I try to do everything, like I pull out every trick and they don't get better, and then it's like, thank God I can like dish them off to the surgeon. They can get a knee replacement or something, especially for like super severe arthritis where they're not getting better with my alternative treatments. So
To add another validation of what you shared about needing to be an advocate for your own health, and you know, unfortunately, certain doctors just go with what they're trained and can actually pass on inaccurate information. There's a gastroenterologist that we both know, I won't mention his name, who suggested that I get a CT scan with contrast on my abdomen just a few weeks ago. And in that conversation, he specifically said, because I brought up the issue of radiation, I said, I don't know that I want to expose myself to that type of radiation. He said, there's zero difference between the radiation you're going to get from that and flying from here to San Francisco, which is a 1 hour flight. I did my homework. That's just not true. I mean, it's just not even close to being true. So my point is that they that I think that, and in fairness, I'm not critiquing here, but it strikes me that, doctors are so busy that they don't have the time, a lot of the time, to stay up to date on medical research and alternative forms of remediation of one's illnesses, et cetera. And maybe are relying on old data or relying on things that are shared with them by the pharmaceutical reps, et cetera. Do you have any comment on that?
Yeah, it's interesting because like when you told me what he said, I had a couple of different thoughts. Like, I don't think he really believes that, and I don't believe that because the typical thing is we say like a cross country trip flight is the equivalent of a chest X-ray.
Mm-hmm.
Like that's what we were taught in medical school. So you flying, it was to San Francisco as the equivalent
Yeah, that
of a
was the
CT scan,
analogy. Yeah, yeah.
right? So to me, I don't. In my heart of hearts, I don't think he actually believes that. He's just like annoyed that like you probably put up a little resistance about getting the CAT.
Yeah.
He said get a CAT scan, and you're like, well, what about the radiation? It's
Yes,
like,
yes.
oh, it's like, hey, go. It's like just flying like San Francisco. Like, okay, I gotta go. You know what I'm saying? So it's just his way of dealing with the resistance of going. The the so I don't think it's like, I don't want to say malicious, but I think the doctors can be a little bit overwhelmed, and he doesn't have time to like sit down with you and like, hey, let's really talk about the risks and benefits of you getting a CAT scan. It's almost like the surgeon. Does the surgeon have time to really sit there and like, hey, I'm going to cut on your body? And for the patient, naturally, is like, I'm not so sure that's a good idea. But I remember when I was a medical student, I'll tell you a quick story because it's all related. So when I was a medical student, I did a plastic surgery rotation, and all plastic surgeons are hand surgeons. They're amazing surgeons. Like I love the plastic surgeons. It's not just the aesthetics they do. Like they do wound care, they do broken noses, they do fractures of your face. They do, and they're all hand surgeons. So whether you have a trigger finger or anything. So I had a patient come in. We saw a patient together in the clinic. This is at Penn State. This is the outpatient hand surgery clinic. The patient comes in with like a trigger finger, and the patient doesn't know anything. She doesn't know what the diagnosis is. So she says, "Hey, every time, like I'll bend my hand and then it locks, or bend one of my finger, it locks, and I have to like click it, and then it clicks and it hurts, and then it opens up." So he explained that it's a trigger finger, and he said, "Well, okay, it's a trigger finger. Why don't you schedule?" And it was like literally a 2-minute visit, and then he said, "Hey, just schedule with the front desk a surgery, the surgical time." And when she put up she started to resist a little bit by saying like, "But do I?" And he was like so frustrated because he's like sleep deprived too. He's like so frustrated. He's like, "Why?" He's like, "Why would you come to a surgical clinic if you didn't want surgery?" And I'm like, "Hey, is it possible that she just wanted a diagnosis and some treatment options?"
Yeah.
She walked in here to a doctor's clinic. She didn't go into like a surgical clinic thinking she's going to have surgery. She's just looking for a diagnosis. So the doctors get so used to doing what we do that sometimes we're just like, the doctors get frustrated if there's any resistance. Like all he could think is like, why wouldn't you want to have surgery for this? Like,
Yeah.
that's what I would want to do. So it's an interesting thing. So there's a bias. Like we all have a bias. The doctors, we all have a bias, like to do stuff. Even myself, like if you came in and it's very hard as a patient, as a doctor, to say like, "Tim, I think the best course of action is nothing. I'm recommending you do nothing. And I'm going to recommend no treatment, no supplements, nothing." That's really like, because as a doctor, that takes a lot of guts to say, "I'm going to recommend nothing," because it's like, what's your value if you actually recommended nothing? I'd have to justify why I'm recommending nothing, and then you'd get it. I'm recommending nothing because I want to see what happens over the next 24 hours. Does this go away on its own or not? Do you spike a fever and then you're going to call me back? But it's very hard for us doctors, including myself, to do nothing. So anyway.
So transitioning, I want to get real specific if we can here. And I mentioned earlier, when I do my retreats in Costa Rica, and they're a 8 day retreat, we go into the depths of a lot of different areas, certainly business, but also into the personal realm. And we talk nutrition and we talk health. And it's always crazy. I ask people to raise their hand if they have not had blood work done in the last 5 years. And it's like 75% of the room, and it trips me out because so I realize that a lot of people are incredibly reactive with their health. And what I would love for you to talk about is a couple of topics, and you can take them in whatever order or blend them together, is what are some key things that the people that are listening should consider as it relates to being proactive with their health? Like what are like the must do, like baseline tests that you should do, and what's the frequency? And then let's tie into that nutrition. And when I say nutrition, I mean more specifically, like, are there some general rules of supplements? Let's start there. We could talk about food later, but some general rules of supplements, like vitamin D is an example. I mean, we know that that's a really healthy thing for people to be taking if they're not getting enough of it. So could you go there with us, please?
Yeah, and whatever I say is probably gonna be an inadequate answer to that, right? Because like it's hard to just like, hey, this is what everybody should be doing, and these are the supplements they should be taking, because you'll see what my answer is. So, okay, so first of all, if 75% of the guys or people who your clients are not getting blood work in the last 5 years, the better question is why. Either they're too busy, right? Like they're super busy and they don't have the time to do that, or they've had bad experiences with their doctors, which is a lot of people, or they don't trust their doctor, or they're scared, right? They're scared that they're going to find something. So
yeah, that fear part, sorry to interrupt you, but that fear part is the one that I think is very prevalent. Like I'll ask, why not? And they'll be like, I'm afraid of what I'll find. I've been smoking for 5 years and, that kind of thing.
Yeah. And, or like, it's really interesting because like, there's a lot of kind of like denial that we all have. Denial I used to think was horrible, but a little bit of denial is probably healthy. So for example, if I have a patient with like a very strong family history of coronary artery disease, like meaning everyone drops dead of a heart attack or they even have strokes in the family, the patient will say like, I'm nothing like my parents, right? Like they used to smoke, I don't smoke. They used to drink, I don't drink. But like literally for 3 generations, everyone's dropped dead of a heart attack. So I think it's almost, some of it's not like, hey, I can never get that because I don't have their lifestyle. But genetics are relatively strong. Environments is like important, right? We say genetics is the gun, right? And environment's the trigger, right? So let's talk a little bit about like preventative. So anyway, why was I mentioning that? Because if you're going to recommend preventative things, it's like the person's got to be in the right headspace to even do the stuff, right? If the person's afraid of finding things, I think most patients, this is my impression, most patients don't want to do things because they're afraid if they find something, nothing can really be done about that. So if I told you, hey, Tim, I want to check your cognition because like, hey, our cognition changes a little bit. But I want to make sure that we're not like decelerating faster than normal, which would be like a sign of us later on becoming demented. Okay, like most people are going to be like, I don't even want to check that because like, what can you do? Now, I know I can do something about that, meaning I, as a physician, know what to do to help prevent, progression of cognitive decline, just like I know what to do to prevent progression of coronary artery disease or any plaque in the body, right? That we can do things to either slow it down or partially reverse it. But the patient doesn't know that. So for the patient's perspective, they're like, why do I want to check, find out bad news, and then just have like surgery and have my life be like totally messed up, find cancer and then be like a cancer patient for the rest of my life. So I totally get why they don't want to do stuff. So I would say the most important thing is just realizing that probably the expectations that the patient has is not in line with what the doctor's actually thinking. Most of the doctors are like, hey, most things are relatively preventable. Okay, so what would be basics? Like the basics probably depends on your age. What's like the average age of of your clients?
Well, let's just say 50.
Okay, yeah,
it's a little lower than that. We can go 45, whatever you'd like.
Okay, so look, it's nice to do like a basic would be an annual blood test, just a simple annual blood test. And it's not like people have to write it down, but CBC, CMP, CBC is like a complete blood count just to make sure there's no anemia, that you don't have too many red blood cells, that there's no leukemia. CMP is a simple blood test just to check the liver, kidneys, electrolytes. It's nice to do a simple basic test of the thyroid. 10% of the patients have thyroid problems, autoimmune thyroid disease without even knowing it. For us guys, it's nice to check testosterone because the testosterone makes a huge difference in how we feel. Not for everybody, but it still has an impact. And then it's nice to check a PSA. So those would be kind of simple blood tests that are easy and not even expensive. So let's say that's another reason why people don't go to the doctor too, because they may get a huge, your clients may be, I assume most of them are self-employed, right? They're running their own business.
Yes.
Yeah. So guys who are self-employed, I'm self-employed, you're self-employed, right? We all have garbage insurance, and or most of us have garbage insurance, and you essentially cash pay. But the lab panel that I just said could be done for like maybe $150 or $180. That's not like a hugely expensive lab panel. There is a, let me think of it for 1 second.
You didn't mention lipid either in that.
Oh, you're right. I didn't mention lipid at all. Maybe that's my butt. Good job. That's that. I didn't mention lipid. I didn't mention hemoglobin A1C. I didn't mention insulin. Those are three things that would be really important to do as well, because it's nice to know what your cholesterol is. It's nice to know if you're the insulin is to see if you have fat around your tummy, and if you're pre-diabetic, it'll show up with a high insulin. And the hemoglobin A1C is to check for diabetes. So it's a blood sugar over a 3-month period of time. You're absolutely right. Thank you for reminding me. That's why I have staff at the office to catch all my mistakes. So you're hired. If this ever turns out poorly, you're hired.
Well, I'm not looking for work, but thank you. I'm flattered.
I know you're not. I know you're not.
I mean, cardiovascular disease is such a pervasive thing in our society, and it's kind of astonishing to me as to how few people actually even know what their LDL and HDL levels are at. And there are, to your point, means that are very readily available to treat those things, like, either natural or synthetic statins. But a lot of people are just kind of flying blind on it. So let's, if we can, segue that now into supplements, because, not going to go into the depths of the story of you proactively did, as a part of an annual physical about over a decade ago, a ultrasound of my arteries. We found a 35% blockage in my femoral artery in my right leg. And my cholesterol levels were not exorbitantly high, but they were I think my overall was like 190 or 195. And it was just as simple as you having me take red yeast rice. And I mean, I've produced some blood tests here over the last couple of years that are like that of a 15-year-old. I mean, I had the last time we did one, I think I was at like overall 140 and LDL of 76. And it's just by, just going to Whole Foods, something as simple as that. So I'd like people to understand that those are options that are readily available, especially have a doctor that's in the know when it comes to these kind of things. Maybe you can give us some other examples.
Sure. Well, first of all, I think you should give yourself, I wouldn't give the supplement as much credit as you, right? Because you can be pretty strict with your diet. And I think when you're producing those really good levels of cholesterol, it's usually not just the supplements. It's a lot has to do with you as well, right? Because you can amp up your exercise, and you really can be strict with your diet, which is impressive. Let me go backwards a little bit, because like we can talk about supplements.
Except for when I'm in Italy, and I'm not. No one would accuse me of being strict when I'm in Italy. So,
like I told you, it's a sign of psychological health. Because if you can't like let go sometimes, then it's like, whoa, the person's so rigid. I worry about the person. So the person at the gym who's always perfect, everything always looks perfect all the time, is usually not the most fun person, right? Because they're so rigid on themselves, and they're rigid on other people too, right? They're just like harsh on themselves, harsh to other people. That's why I'd say in general, someone who's like totally out of shape, they're like usually very permissive, and they're usually very fun, right? Like finding that sweet spot is probably the most important thing. But there's a reason why someone who is chubby and hilarious, when they get super fit, they're usually not hilarious. They're like usually very serious afterwards. Mm-hmm. Because they're like on a mission.
Yeah. So, before we go to the supplements, I was going to go to this place anyway, so we're there. So what is that sweet spot, and how do you advise your patients to try to thread the needle between being so vigilant and intense that it's actually unhealthy, because the psychology of it affects our entire physiology, versus someone who's maybe just too lax and not proactive enough. So what means of coping do you suggest? Is it meditation? Is it, exercise? What are some of the things that you think are important for people to do if they fall into that category?
Okay. So I'm lucky, because when I do the labs, I can sometimes tell, hey, is something like aesthetic or something health? So someone who, like I had a patient I saw yesterday, and I think she had lost a lot of weight, but she's probably objectively still 45 pounds overweight, but her blood work's amazing. She has like perfect cholesterol, perfect blood sugar, no insulin resistance, a normal hemoglobin A1C. She's very healthy. There's some people who are overweight and it's an aesthetic issue. It's not a health issue. So those are the patients that just tell them straight out, like, hey, I'm happy to tell you that you don't have a health problem. If you want to lose weight for aesthetics, aesthetics are important too, right? We live amongst other human beings. So aesthetics are important, but it's just nice to differentiate that. So that's usually what I get to determine that based off some of the blood work to see like, hey, is this a health issue or is this like a personal aesthetic issue? Now, what do I recommend for people to do to like kind of keep that balance and not be overly intense? Boy, that gets into a lot of like deep psychology too, like how we're all a little bit screwed up, you know, from whatever our childhood experiences and how we get into a certain survival mode and we tell ourselves certain stories that we have to like keep up. So I think it depends on how severe the person is or severely harsh the person is. I usually think like threading the line is like just having some basic self-care each day, right? For me, I like playing sports. So I'll give you an example. Like, what do I do for myself? Like the idea of working hard all day and then torturing myself, like at the gym, like on a treadmill or on a stair stepper to do like an hour of cardio. That would be like a typical female thing. Like I work super hard and then but I have to exercise. So they'll do like an hour on a stair stepper. It's not like something they look forward to. So for me, you know, we talked about playing pickleball or I'll go to the gym. I haven't been surfing as much, but those things are like super fun, right? So like I'm like a kid that at the end of the day, it's a treat for me to move my body and exercise.
Mm-hmm.
So that's how I think about it. Like instead of it like being an obligation, it's something that's enjoyable. In theory, food could be the same way, right? It's not like, oh, I have to eat healthy. You can make the healthy food taste good and it could be enjoyable. But I'm pretty nice. I try to be nice to myself, right? And not beat up myself too much. And I'd say the same thing with the patient. If I see the patient not enjoying anything, right, that they're trying to do everything right all the time, sometimes that is like crosses a line, right? Where they don't feel good, right? Or we had talked about maybe in the past, it's hard to make your body feel safe if you're constantly thinking if the constant thoughts in the body are that like, I'm not okay or I'm not healthy. So sometimes when we try too hard at stuff, it's actually like counterproductive to having a sense of well-being. So
Mm-hmm. Mm-hmm.
I was going to say, I don't mean to interrupt you, but I was going to say like, cause we're talking about like what preventative things, we just talked about a little bit of blood tests, but honestly for like the group of people who are likely to listen to this, I would say there's one, if they don't want to see a doctor at all and just do like one test, like what would be the one test I would recommend for everybody? That would be a CT calcium score.
Mm-hmm.
So a CAT scan of the heart, checking for calcium deposits in the heart. And I can't disclose what your score was, but you can.
My score was perfect. I had 0, but that brings up an interesting point, which is, yeah, I was super grateful of that. Now, the CT there, I took 2 tests. The first one was a CT calcium score, and then the second one was with contrast.
Yeah, the CT angiogram was because like, hey, are we missing soft plaque? Okay, so let me explain what the tests are. The CAT scan is radiation, right? It's a CAT scan of the heart, so multiple X-rays of the heart, and you're looking for calcium deposits in the lining of the arteries. Now, that's very valuable. This test, by the way, is a $200 test. So if someone wants to look at like return on investment, that is like the biggest return on investment. I'd rather not check someone's cholesterol for 10 years, but have a CAT scan of their heart, right? Mm-hmm. Then I actually know how serious is their condition. Do I need to be aggressive with them or do I not need to be aggressive with them? So the first one we did was negative in your case. And we want to make sure that you didn't have some type of soft plaque that was hiding there to be like, hey, is there soft plaque that we're missing? Because I'm like, I'm not so sure. If you had plaque on ultrasound and I wanted to be 100% sure, that's why I did the CT angiogram. But for most patients, even myself, like I have a strong family history of coronary artery disease in the family. So I did my first CAT scan at like 42 and I did my second CAT scan at 50. Thank God both of them were negative. But that doesn't mean I'm not putting on a little bit of soft plaque. So that's why I love doing the ultrasounds in addition to that. So in our office, you know, we do the ultrasounds, the carotid, and then the femoral arteries, the groin arteries, behind the knee arteries. But as I can tell you, have your clients they have these mobile ultrasound places called LifeScan. Okay. And it's not super expensive. That's like a few $100s. And they will check the carotids, they check the aorta for an aneurysm, and they do they don't check, how like we do the ultrasound of the groin and behind the knees. They don't do that. They just do a blood pressure cuff on the ankle. But for the amount that they charge, it's actually quite a good thing. So, and you don't need a prescription for that. A lot of times they do that at someone's church, or you just go on their website, LifeScan, and you can find out when one is. So LifeScan's good, CT calcium score is good, and you can ask any doctor for your CT calcium score. Any of their primary care doctors usually have to ask them to prescribe that.
That's super, super valuable. I'm glad that we went here, and I think that everyone could benefit from that. I have a quick question. How frequently should one do a CT calcium score? Because I mean, the last one I did was probably close to 10 years ago now. Am I due for another one in your opinion, or?
Okay, so this is the thing is, if someone's positive, then I don't keep usually repeating the scan, because then I already know they have coronary artery disease. We can know, based off having done so many hundreds of thousands of these right in the past, like how you compare to other people. And then we know the calcium score goes up in time, even if the plaque doesn't go up. So I'll give you, this is where things get messed up. So let's say someone had a 20% blockage in their LAD, left anterior descending artery. By the way, there's a good documentary called The Widowmaker, and it's about the doctor who made this test. He's also the author of the South Beach Diet, the guy who made this test, Dr. Agatston. So it's pretty cool that that guy's a very unique doctor, right? He's like a cool doctor who made the South Beach Diet, but he also made the CT calcium score. So really cool doctor. Anyway, let's say you have a CAT scan, and the CAT scan gives us a number. It doesn't tell us the percent blockage. So let's say someone has a calcium score of 100, which is like a mild to moderate amount of plaque in one of the arteries. If we follow up 5 years later, that calcium score of 100 is likely to be like 170, 200. It's likely to go up, but the person's plaque may actually go down. So let me explain that. So if you had a chunky soft plaque and 20% of it, let's say you had a 30% blockage and 20% of it was calcified, you fast forward 5 years, the plaque has actually shrunk because you treated the patients with either natural things or cholesterol medicine. So let's say the 30% blockage is now a 20% blockage, but more of it's calcified. Your calcium score will go up, but you could even have less plaque. So I don't keep repeating these over and over again, because it doesn't really like help the patient, right? To know like, okay, your calcium score went up. That's almost like confusing for the patient.
Mm-hmm.
Once I know the person has plaque, I know they need to be treated. And I usually try to find plaque elsewhere to be like the surrogate, so we can keep monitoring. Like if we're monitoring you, right, you haven't had any like new developments. So it's kind of like a good sign, like you're not putting on any plaque anywhere else.
Okay, great. So I'm in the clear to I still want to get back to supplements in a second, but
yeah,
I want to actually ask another question, because we're on the subject matter of CT scans, and there's always the subject matter of radiation. So what's the difference? When would one want to do a CT scan versus an MRI? What's the difference between the two? Because an MRI does not include radiation and a CT scan does.
Okay, so
because I know that, sorry to interrupt, but I know that like a lot of people that are proactive with their health, they'll do like the full body MRI,
right.
and so what is the difference between the two, and is one better than the other?
So the CAT scans are X-rays. So we know when we do X-rays are really good at looking at bones, for example. So when we do a CAT scan of your heart, and CAT scans are cheaper, and CAT scans are faster, and CAT scans don't cause claustrophobia, because it's like just like a little ring, right? You go into, so it's a lot easier than going into like a tunnel or a tomb. So the default for the doctors, it's a lot easier to prescribe a CAT scan, even though it has radiation, because the patient's going to tolerate it better. It's going to be more likely approved by the insurance. It's going to be a fast exam, like 5 minutes. So that's why. And with regards to the heart, that's different, right? The heart is beating and moving. And you're looking for calcifications in the coronary arteries. So calcium deposits the same density as a bone, right? So that's why we do the CAT scan of the heart versus doing an MRI of the heart. MRI of the heart, there is actually such a thing as doing an MRI of the heart, but it's actually relatively new. Cedars-Sinai does that, for example, but it's actually on the more innovative side, and it shows you something slightly different than what we're talking about. Okay, so CAT scan versus MRI, that's something you literally have to push your doctor on. Like, hey, the doctor wants to do a CAT scan of a certain area. Do I need a CAT scan or can get an MRI? For a whole host of reasons, we tend to do CAT scans of the lungs and we can MRI everything else. So in general, if you need something of your lungs, we do a CAT scan. And partly because the lungs are moving, right? You can't just have the patient not breathe while you do a 30-minute MRI.
Yeah.
So that's not compatible with living. But you can have the person hold their breath when you do a CAT scan, and you can they can literally scan very extremely fast. Mm-hmm. So lungs tend to be done with a CAT scan, but almost every other part of your body you could ask for an MRI. Your insurance may not approve it. It may be more expensive. It may be more claustrophobic, inducing. But that's somewhat what we decide. The general rule is CAT scans are better for bones. MRIs are better for soft tissue. So like if you tear, that's why you get an MRI of your knee, right? When's the last person went in for a CAT scan of their knee? You go for an MRI of your knee because it can show the meniscus, it can show the cartilage. A CAT scan will show some of that stuff as well, but it'll show the bone better than it will show the other soft tissue.
So an MRI, so soft tissue would be things like liver and gallbladder and things like that?
Soft tissue would be that. Those would be like organs, but like soft tissue is also like your muscles, your tendons,
got it.
Stuff like that, right? Cartilage.
Okay.
So it's hard. So see how vague medicine is?
Yeah.
Like your questions are such good questions, but like, that's why I say I knew some of these answers are going to be like inadequate answers because it always depends. And that's an annoying thing for someone to say like, hey, when should I get a CAT scan? When should I get an MRI? Of course, the answer is going to be, it depends. It depends on what body part. It depends on your insurance. It depends. Like we treat like 85-year-olds different than we treat 50-year-olds and 20-year-olds. Like if you're irradiating, if you're giving a CAT scan, let's say someone needs serial CAT scans and they're 22 years old. That's like giving them sunburns, right? It's like burning their skin. That they're much more likely to get a skin cancer, right? So if you're exposing them to radiation and they're in their 20s, then it has a longer time to affect them later on to potentially cause cancer. When you're giving a bunch of CAT scans to an 85-year-old, it's like sunburning an 85-year-old. Like, are they going to get skin cancer 20 years later? Like, God bless them. If they get skin cancer at 105, that's like amazing. But so you see what I'm saying? Like, it depends the age too. Like, how dangerous is that? As a side note, by the way, that's what, like talking about trying to be innovative. I don't know if you've ever picked up at the office. This is not a plug because we only have it in our office, but I'll tell people what they could get if they have to get a CAT scan. I don't think I've ever given you something called X-ray armor. You have a supplement?
Absolutely, okay. You did.
So that X-ray armor, I think appropriately named, is something that like I formulated. We have it in the office, but it has 20. What's the active ingredients? 20 milligrams. The biggest ingredient there is 20 milligrams of melatonin. It also has lycopene in it, and there's one other ingredient. But what's the deal with melatonin? Melatonin is considered a like radioprotective. So if you're getting radiation therapy and you take melatonin, it helps prevent the damage to your DNA because that's really what you're looking forward to, right? You don't want the X-rays to like damage the DNA to induce mutations that could drive cancer. So that high dose of melatonin, you'd think 20 milligrams would make you somehow like sleepy during the day. But you take it about an hour before a CAT scan, and that can help protect you from the radiation. That's not based off studies that I did because like that would take me like 5 years of like my life to do those studies. But that's based off research that's already there in the journals that show that where they checked people's breakdown, they had radiation therapy, and they showed that people who were taking melatonin had less breakdown products of DNA in their urine when they took the melatonin versus when they didn't. So it's considered radioprotective. And if you Google that, just put that into Google, melatonin reduces harmful effects of radiation. So.
Well, that's a perfect segue into supplements, right? Because that's a perfect example of a natural supplement that can be used in a preventative way. What are some things that people should consider? And I realize every human being is different, but I think that there are certain things like vitamin D, I would presume, that are just good general rules of thumb. Maybe you could share that.
Yeah. And I don't mean to disappoint you with this stuff, but believe it or not, I don't have like a hard and fast rule about like supplements because taking supplements, like just like taking medicine can be annoying. I find it annoying to take, and I take supplements. And then I'll take supplements like very intensely. And then I'll be like, oh my gosh, like I need a vacation from my supplements. and I take like a week off and then go back to it. So with regards to, hey, is there one thing that's everybody should take? That's why I do some of this based off the blood test, right? So if when we do the blood test, I didn't say check vitamin, we check vitamin D, we check B12, and then those recommendations are usually based off that. If the person, we don't check like vitamin C in the blood or alpha, and these other supplements that we sometimes recommend, NAC, alpha lipoic acid. These antioxidants are very good, but I usually do it based off whatever disease process they have, right? So if I see that there's inflammation in their body, then there's certain supplements I recommend. But I don't always do those based off the blood work. So believe it or not, I don't have a blanket statement like, hey, everyone should take a multivitamin or everyone should take vitamin D. I'm having a back and forth with a naturopath. She gave one of our mutual patients a handout that was showing like the harmful effects of high levels of vitamin D in the blood. And it's so interesting. So there's studies that show high levels are like not good for you. And there's other studies that show high levels are great for you. So medicine can be complicated. And this harkens back to what we were talking about in the beginning, is that I can probably find research to support whatever I want to give. What does that mean when we can find that this helps and the same thing hurts? It usually means the effect is very minor. Does that make sense?
Yeah.
Or that it should be given in moderation. Because like if we did a study on exercise, if it's moderate exercise, it's almost like every study is going to show it's helpful. But if I exercise someone so hard that they have heart attacks or tear muscles, right, then it's not good for them. So it's weird. Like almost everything is like helpful and harmful. There's probably a moderate dosage of everything that works. Like I'm saying, the other way I think about these things is when there's two contrary things in medicine where the same thing helps and hurts, then I just kind of like, it probably has a minor effect overall. So what do you take? What do you typically recommend for your clients?
I don't get into recommending anything for my clients, but what I personally take, let's see, I take CoQ10, I take vitamin D, I take B12, I take DHEA, K3. No, that's actually vitamin D has K3 in it. The red yeast rice, I mispronounced it as hydraulic acid. I can't remember
the hyaluronic acid.
Hyaluronic acid. I think those are the things that you and I have had me on now for quite some time. And my blood work tends to perform quite well. Now, there is one other thing that you've had me on for a very long time that is not a supplement, but I do want to talk about this. It's funny because I have more and more people come to me and say, do you know anything about TRT? And I'll say, well, yeah, actually, I've been on testosterone replacement therapy for over a decade now. When you had suggested it to me, it was to hopefully have an impact on my migraine headaches. And I was also having, some crashing during the afternoon, like 2:00, 2:30, getting super tired, having to jack myself up on a little bit of sugar or some caffeine to get me through the day. And, started taking that. I know that for me at the beginning, doctor, it was like, I didn't want to talk to anybody about it because I felt like I was a little bit of a cheater, I think that's kind of a psychologically common thing. And my testosterone level was at around 400 at the time, which is too low. It wasn't as low as some people that I know. But boys, it made just a really nice difference, and we've found a sweet spot with it. I take, if you recall, extremely low dosage of it. In fact, sometimes you're really surprised when we review the dosage. I only do it once a week, and it's like half of what somebody usually takes twice a week, and it gets me right to that 800 or 900 right in their range. Mm-hmm. But what I'd love for you to talk about is the benefits and why someone would want to get their testosterone checked. And does it only apply to men? And what are some of the things that are symptoms of low testosterone and the health negatives and the health benefits of having your testosterone at regular levels? I know I asked a lot there, but maybe you can summarize it.
These are like awesome questions. And it's like, oh my gosh, like the thorough answer would probably be a half an hour answer. But I'll give the Cliff Notes version, like what we would do in the office. Same thing if I just was reviewing someone's labs and a testosterone. It's funny because we don't typically see testosterones that are outright like low. When they're super low, there's usually something wrong with the patient. Like they have a pituitary tumor causing that, there's something wrong. Like there's a medical metabolic disease causing it, or an endocrine disease causing it. What's more common is like things decline as we get older, right? Like an 80-year-old doesn't have the same testosterone as an 18-year-old, and yet they don't have a disease. So this is one of the interesting things. Like this is the whole idea of why anti-aging medicine came around. What do you call it when something declines, but there's no disease? So for guys, like if I'm a 52-year-old guy, is it normal to? It's not going to be normal to have the same testosterone I did when I was 18, right? It's more common to have that decline like precipitously. Okay, so what are typical symptoms of low testosterone? And this is something that I can tell you based off experience, right? Like talking to every guy about this for 20 plus years, there's certain patterns and certain generalizations I can say that if 50% of the guys, in my opinion, are very sensitive to testosterone. They're like testosterone sensitive guys. And then 50% of guys are not testosterone sensitive guys. They may still respond to testosterone, but it's not life changing. So let me say this: 50% of guys I give testosterone to, they will literally say, "You saved my life. You changed my life. Like my life is like so much better," which seems like very dramatic just from giving someone testosterone. And the other 50% of guys will be like, "Hey, I do feel better." Like so what's the difference between these two guys? Some of it has to do with like the natural sensitivities that we all have to hormones. Just like some women are very sensitive to hormone fluctuations in their brain, some guys are very sensitive to hormone fluctuations in their brain. And when their testosterone is low, they have the following symptoms: fatigue, depression, cognitive decline, lack of ambition. This is like a common thing. Like the guys who are just like very like placid instead of being like how maybe we were more aggressive. Everyone who's coming to you is like was aggressive or is aggressive, right? They wouldn't be seeking your help if they weren't kind of like highly motivated. But they'll notice like there's sometimes in our life that we're, as all of us are self-employed, there's times in our life that we're very ambitious, and there's times where like, oh, I should retire, I should back off. So a lot of times when we're feeling those kind of more negative things, it's our testosterone could be low. So then there's also loss of muscle mass where your body doesn't respond the way it used to. Then there's libido, sexual function, lack of erections in the morning. So that'd be one of the simplest ways to know, like, hey, is your testosterone low? Is like when you were younger, if you used to have, 5 erections per week, wake up with 5 erections per week in the morning, and then you go urinate afterwards. If now all of a sudden it's 0 or 1 or something like that, you can kind of tell that, hey, the testosterone's low. Sometimes having a lower testosterone makes your spouse like you a little bit better because you're not like, you're not as like, desirous of relations. You're a little bit more mellow. Like sometimes it's cool. And actually, believe it or not, I think that's something that I'll definitely talk with the patient about. Like, hey, how's your relationship going and stuff like that? Because if you give testosterone replacement for a guy and there's already a little friction in the house, sometimes the guy will be feeling much more youthful and vigorous. And if there's already a discrepancy, you don't want the guy to feel more shunned and then like seek attention elsewhere, because that causes more problems. Anyway, so those, I'd say, the typical symptoms, right? Like where the person is like, and the person, so the benefits are better energy, better mood, better sex drive, better sexual function. And it's amazingly enough, cognitive tests, people improve on testosterone. And you would think it's the opposite, right? Because we have guys have a reputation for like, if your testosterone's high, you're like a meathead or an idiot. But the studies are pretty clear that when the testosterone is high, people perform better cognitively as well. So
is there any link? Thank you for that comprehensive answer. Is there any link with testosterone and it helping with the curtailing of, say, prostate cancer and or Alzheimer's, dementia, anything like that?
Yeah. Okay. It's a sophisticated question, because the first part of the question I'll try to answer. Testosterone, it's weird. There's an inverse relationship between testosterone and prostate cancer, meaning testosterone levels and prostate cancer. The lower the testosterone, the more likely you're to get prostate cancer. But why is that? That's because older people get prostate cancer and older people have lower testosterone levels. So it's not a completely fair thing for me to say like testosterone, like, it doesn't mean that testosterone prevents prostate cancer, but I can tell you literally clinically from doing this, because that's my job. When I give someone testosterone, I have to check their PSA, make sure they don't get prostate cancer. So from doing this like all day, every day, there's a very clear pattern. And the research is very, very consistent. Testosterone does not cause prostate cancer. But if you have a prostate cancer, testosterone can grow a prostate cancer. So the way I typically say this is like, what I tell a patient is like, if I'm your gardener and I show up, and I show up and your lawn is perfectly green and I fertilize the lawn and you water the lawn, it stays super healthy. And if it's all perfect grass, there's almost no place for weeds to grow, right? It keeps it like healthy. And in this analogy, the testosterone would be like fertilizer and weeds would be cancer. But if I show up to your lawn and it's, 20% crabgrass and weeds and 80% grass, and then I just am fertilizing your lawn like this, right, before pulling weeds and pulling the crabgrass, then you're going to have growth of the weeds. And it's the same thing with testosterone and prostate cancer. I've seen it in my patients too. If you give testosterone to someone who has prostate cancer, the PSA will go up. So I can use this to my advantage too. Like someone who's afraid of prostate cancer, so check the PSA, but if I give them testosterone and their PSA jumps, it's like, whoa, that was like a stress test for their prostate. So it's like, whoa, let's pull back on the testosterone and let's check that prostate. Let's do an MRI of the prostate and make sure there's no prostate cancer. So instead of sending someone for biopsies right away, we do MRIs of the prostate now. So that's usually good. One thing we didn't talk about is why some of the guys don't go to the doctor is like a prostate exam.
Well, it used to not be fun, but then when you stopped using your finger about 15 years ago, I didn't mind you checking it.
Okay, so I think standard of care is still using your finger.
Yeah.
And I will still do that periodically, depending on how much I dislike the patient. No, I'm just kidding. I would never do that for that reason. The only time I use my finger is if the person has pain. Like if the person has prostatitis, I can't do an ultrasound to see if they have prostatitis. I have to actually push on their prostate. And if their prostate hurts, then I can say, oh, this is consistent with prostatitis. But when you and I are screening for prostate cancer, I'm screening for prostate cancer in the clinic. What's the value of sticking my finger and I feel like, no, like I can just do the ultrasound and I have the volume of the prostate.
I just found the
PSA.
Sorry to interrupt you, but I just found the perfect reel for our Instagram account was you doing this. We're going to definitely put that on social media.
Do not do that.
Okay. Sorry for interrupting you, but you're going to the ultrasound of the prostate as the way to check for prostate cancer as well, right?
So the ultrasound, the way I'm doing it, which is transabdominal, right? Like where you just do it lower than your belly button and just put it over your bladder. Mm-hmm. So that's not invasive at all. And I get the size of the prostate. I can see if there's prostate stones. It's like awesome. To me, it's awesome. And you take the volume of that prostate, which I know what it's supposed to be when you're young, and then it gets grows with time. And then you divide that by the PSA, and then there's a certain ratio that we look at. So, and then that's, I take that back. It's the PSA divided by the volume. So that ratio is like, there's a certain number that makes us know, hey, this is safe or this is not safe. Should we do a biopsy? Should we not? And to me, this has been like awesome. And like the patients are happy. I think it's cooler. I think it's way more dignified. And then you have to be also like, if you're being scientific, what is the value of just sticking that finger up there, and like pushing around? I don't think the value is as high as the urologists like to say. I think it's doing an ultrasound and having this, what we call prostate density. The studies are very good about that as a screening test for prostate cancer.
I mean, I always wondered, I never asked you this, or any doctor for that matter, but it can't be a whole lot of fun for you to have to do that either.
Hey, being a doctor, when you sign up to being a doctor, the reality is we're not grossed out by that stuff. The only thing it is what it is, right? Because like we're dealing with all different body parts, right? And honestly, we take the high road with this stuff. My job is to take care of your body and to not neglect different parts of your body because like, one is, more pleasant and one is less pleasant. So I think in that case, like the doctors in general are mission driven, right? And it's my job to take care of you. It's really my job and my duty to take care of your body and not be disgusted. I used to work one of my first jobs. I worked at urgent care, and I had to do DMV physicals for these long haul truck drivers in Ohio. And I would check their feet too, right? Like this is part of the exam is you check their feet. Some of these guys have been on the road for like 5 days and didn't shower, and it's in the middle of winter and stuff like that. So it's not like pleasant, but like your job, that's, we're being paid to be professionals, and that's part of our job. So that just comes with the territory.
Well, I can't imagine ending this beautiful conversation on a better note than fingers up buttholes and that kind of stuff. I wonder what it would have been like if we would have started with this. Like if we would have reverse engineered the order of our discussion and we would have started with checking one's prostate. I wonder if the listenership would have dropped precipitously or if people would have just said, "Hey, I can't let go of this. I got to keep listening because who knows what's
I
coming."
think I think it'd be better. It would have been better.
Thank you so much for your time. I know how valuable it is. I know today I think is your day off, so thanks for taking the time to chat with me. And I know that people are going to get tremendous value from your wisdom, and I'm really grateful.
My pleasure. My pleasure. Thanks for chit chatting with me.
You're welcome. And I want to say thank you everyone for listening and appreciate your time and want to wish everyone a beautiful rest of your month. Bye-bye.